Dr. Rutul Goklani. I'm National Convener and Coordinator for Digimed Group. Digimed Group is 6 years old now. This is a group of young diabetologists. One of the youngest diabetologists is Dr. Bharat Sabu, who is our mentor, who joined the group as a group member, and now he is helping us as a mentor. And today's our program is on diabetic foot and diabetic foot, what the physicians must know and do. This is what we are going to discuss. And for that, we have Dr. Vijay Vishwanathan, sir, who is MD, PhD, FRCP, and he is head and chief physician at MV Hospital for Diabetes and Professor M. Vishwanathan Diabetes Research Center that is in Chennai since last 33 years. He is president-elect for RSSDI for 2023-24, and he has conducted successfully Save the Feet, Keep Walking campaign for RSSDI in 2022, as we all know. And he is recipient of first Vivian Fonseca Award from ADA for research on diabetes and TB in 2013. So it's really a great achievement. He has published over 200 original research papers in diabetic foot and diabetic nephropathy, diabetes and TB, and socioeconomics in diabetes. And today's speaker and our expert is Dr. Vijay Vishwanathan, sir. And today's moderator is Dr. Bharat Sabu, who is director of Prayas Diabetes Center, and he is from Indore. His CV is very long, and I would request him to start the session and to introduce our chairpersons and panelists.
Thank you, Rutul. First of all, it's an honor to be here on Diabetes Dynamics, because this is such an exciting platform where we will be talking about the things which are seldom missed in day-to-day OPDs, especially diabetic foot. And we all know that diabetic foot is a much neglected entity as far as diabetes care is concerned. So first of all, kudos to Digimed Group, our own Digimed Group, and all the members for bringing this up forth, for highlighting this. And we are also thankful to Dr. Vijay Vishwanathan, sir, for humbly accepting our request to be the esteemed faculty, because there can be no other than Dr. Vijay Vishwanathan, sir, to talk about food, because Dr. Vishwanathan, sir, has so much work which he has done in and around diabetic foot. As Rutul has told you, he was pioneer in the Save the Feet, Keep Walking campaign for RSSDI 2022, which was a massive hit. And actually, he is very passionate about treating diabetic foot and keeping patient amputation free. We are also privileged to have three of other esteemed panelists, which will be with us, and we will be having their share of knowledge with us along with Dr. Vijay Vishwanathan, sir. First is Dr. Akash Patel. He's our expert panelist. He has a vast experience in diabetic foot ulcer management, gestational diabetes, and management of CKD and diabetic kidney disorders. Our next panelist, can I have the slide? Dr. Shivani from Bhatinda. She is actually having a vast area of interest into young diabetes, metabolic bone disorder, and she has been awarded with ESI Trainee Grant Award for the year 2018, more than 30 publications in national and international journals. The third one is Dr. Rahul Mopari. Can I have the slides for Dr. Rahul Mopari, please? Dr. Rahul Mopari is our third expert panelist, whose area of interest are juvenile diabetes, hypogonadism, obesity, and pubertal disorder. And he and other two panelists will be assisting Dr. Vijay Vishwanathan, sir, in solving the quench of all our delegates which are there. I just came to know that we have more than 1,500 delegates who have registered for this massive event. So just few housekeeping rules before I hand over the mic to Dr. Vijay Vishwanathan, sir. All the questions would be taken up in the end of the session. You can post your questions in the chat, and we will be taking each question one by one. Don't go anywhere else, because we will be having Dr. Vijay Vishwanathan, sir, talking about diabetic foot, what physicians must know and do. Over to you, sir.
Me, Dr. Rahul and Dr. Akash, also who are in the expert panel. And I'm also very grateful to DGNS, which is I'm so happy that a young diabetologist group has been formed and you're all part of it. and I wish you all the best in the coming years. So, in the next 15 minutes, let me talk to you about uh, finding the laser point. I'm going to talk about what the physicians should know and do. So, I feel the physicians are taking a back step when it comes to the foot, but the foot is an integral part, and we are very much involved in foot care than our other colleagues. So I think it's very important that we take the steps to save limb salvage people who have a diabetic foot issue, foot complication. So this is a slide which Dr. David Armstrong often quotes. So this you can see that peripheral artery disease is as much death as possible. The survival, 5 year survival, is is worse than many other ischemic ulcer, peripheral artery diseases, as bad as pancreatic cancer and lung cancer. And amputation also, neuropathic ulcer. You can see that they are as important as any other cancer. So why talk only about cancers? Why should we get scared about cancers? We should get scared about diabetes and diabetic foot also. This was a study which we published in Diabetes Care in 2006, an old study, where we found that people coming from the rural areas of India, rural parts of Tamil Nadu, my state, have more complications than people coming from the urban. So this is the situation all over the country, all over India. So what I'm saying for my state, I think holds good for the whole country. So I think uh, there is an urban-rural divide in the prevalence of food complications. And people from the rural areas are smoking more. In this study, we found they're smoking more, and there is more of barefoot walking, and so on, and so forth. And so much so, the rural people have much more complications in the foot than in the urban population. This photograph shows you the face uh, sad face of people. The only this ward boys are very happy because the photograph is being taken. So everybody is so sad that they've lost a leg due to diabetes. So nobody should lose a leg due to diabetes. This should be our motto. This was a study which we published in 2011, where in JAPI, where we looked at 1985 people who had undergone an amputation. And we found that the commonest cause of amputation was infection. So, infection, the pus pouring out, is a common cause in a neuropathic feet uh, for amputation in India. This is in India. This was a study which was done in 29 centers: Uttar Pradesh, Madhya Pradesh, Rajasthan, Tamil Nadu, Orissa, everywhere. And we found out of this sample size of 1395, we found that most of the patients had amputation. So this is a beautiful algorithm given by Mike Edmonds and late Ali Foster, who died of cancer. Now, normal foot and high risk feet, stage 1 and 2, are the stages in which we physicians can be involved. Once it escapes into stage 3, 4, 5, 6, then becomes very expensive. It becomes you need to do offloading and you need to do so many things, which I talked to you in a, in 5, 10 minutes. So the stage 1 and 2 is a stage in which we physicians, we members of the D Genius are involved. So please do not forget that if you see 10 people coming into your clinic, into your room, into your chamber, about 4 people have a high risk feet. 4 out of 10 have a high risk feet. And this is what we found in the Save the Feet campaign. About 30 to 40% of people had high risk feet, as we examined with the Sims monofilament. And neuropathy is very common in the commonest cause. Francis Game, who heads uh, the IWGDF now, said that the best classification system is a Sinbad classification and not the University of Texas, because neuropathy, loss of sensation, is not taken into account. I told Francis Game, who was the chair of my wound healing group in IWGDF, that all the patients in India have neuropathy. And this was an article which we wrote along with American and British neurologists, David Bennett and James Russell, and so on. So, from in Nature, this was written in 2019 before COVID. Therefore, neuropathy is very much to be tested. Loss of sensation is to be tested in all the 10 people, because you don't know who those 4 out of 10 people are. So you have the large fibers and the small fibers. The small fibers have very little myelin in it, whereas the large fibers have a lot of myelin in it. So they are motor fibers, large fibers, and they are in charge of muscle control. Whereas the thinly myelinated fibers, unmyelinated fibers, the A delta or the C fibers, are the small fibers. Dan Ziegler of Dusseldorf has said that the small fibers are involved first and then the large fibers. So if you test for these two, large and small fibers, about which I'll talk to you in a minute, then your job is done. Now, Neuropathy Disability Score Indias was given by by Andrew Bolton and Carolyn Abbott from Manchester. They said you have to do the vibration test with a 128 hertz tuning fork. You can measure the temperature, you can measure the pinprick, and you can look at the ankle reflex, the Achilles reflex. And if the ankle reflex is gone, you give 2 marks for the right side and left side. If all these features are absent, you give 1 point, 1 mark each, one for abdomen and 0 for normal. Whereas for Achilles reflex, ankle reflex, you give 2 points. So you get an NDA score of total of 10. And what Carolyn Abbott, who was a research student under Professor Andrew Bolton in 2002, showed was, if you have a more score of more than 6, then you will ulcerate more than if you have a score of less than 6. So this was the finding of the NWDFCS results of Carolyn Abbott. Now, what do we do in India? In India, uh, the DFSI, led by me, we validated the sensitometer and the biothesiometer. And the two companies which make the sensitometer are the Codis and the Diabetic Food Care India. And we also have a company from Bangalore, Yostra, which has a instrument which has the vibration, temperature, everything in it, the NeuroTouch. And it is led by Vinayak of Yostra, company in Bangalore. So this is, if you don't have that instrument, then you can use the temperature perception for small nerve fibers. Riaz Malik he's now in Qatar. He was in Manchester earlier. He's in Qatar. He talked about the corneal confocal microscopy, CCM, where you can look at the small nerve fibers in the eye and make a diagnosis of small fiber neuropathy. But it's an expensive machine. It's costing 25,000 rupees. Now, this is available with some companies in India, the tip term, and I published in 2002 the metallic end and the wooden end. And this is called the tip term, where you can make out the difference in temperature. The large nerve fiber can be tested by the biothesiometer or by the 128 Hertz 24, as Carolyn Abbott said. So don't forget that about 30% of our patients have peripheral arterial disease, PAD. So you have to test the dorsalis pedis and the posterior tibial pulse by keeping the probe. Many times there would be swelling, so you can't feel it. So the best thing is to use a Huntley, or you have Chennai made uh, handheld Dopplers, which can examine the feet for peripheral arterial disease. So this is what it is. Now, if you have any of these features, any one feature, then you have a high risk feat, which is described by Andrew Bode, by Michael Edmonds and Ali Foster. One or more of the following, that is, if you have lots of protective sensation, by any of the methods which I told you, absent period pulses by the either the pocket Doppler or by your hands, severe foot deformity, history of foot ulcer. If the person says, I had one toe amputated 5 years ago, and prior amputation or limited joint foot mobility, if you can't move the big toe beyond 60 degrees, you have the prayer sign in the upper limbs, but in the lower limbs you can't do the prayer sign. You have the flex, the dorsiflexion of the big toe beyond 60 degrees. If you can't dorsiflex the big toe, then you have limited joint mobility. If you have a goniometer, if you have a physiotherapy, you can measure the subtalar joint movement and demonstrate a limited foot joint mobility. Now, this is again given by colleagues from Mike Edmonds and Ali Foster from King's College. If you have the 6 controls, any ulcer will heal. Any ulcer in the foot, any infection in the foot will heal if you follow these 6 steps. The mechanical control is mostly belonging to D genius. The wound control is mostly the physician, D genius diabetologist or physician, and a surgeon. Microbiological control is both. Vascular control, there's this magic happening in India now by the interventional radiologists, and they do angioplasties of the anteritibial artery, posterior tibial artery, peroneal artery. So you need a vascular surgeon, or you can do a bypass. So you have interventional radiologists. Metabolic control, giving insulin 4 times, is a physician's job. And educating is also a physician or a paramedical staff's role to play. So if you have any of these 6 controls missing, then the ulcer will not heal, the infection will not heal. So this was given by colleagues from the King's College. Now, what are the modern techniques which are available? One slide is missing. The modern techniques which are available, the negative pressure wound therapy, this has revolutionized the wound healing in the last few years. And if you apply the sponge, which costs about 8,000, 10,000 rupees onto the wound, it sucks up the interstitial fluid and the wound contracts, and it helps collaterals to open up, and it helps the revascularization. So this is a beautiful therapy. It should not be used in people who have peripheral artery disease. It is contraindicated in infection and in peripheral artery disease. There are some surgeons who use it in the theater. It's wrong. Only the granulation starts, you should start using the VAP therapy or negative wound pressure therapy. Now the person with diabetes is in the center, and we have a team-based approach. You see a diabetologist, dermatologist, primary care physician, podiatrists who are missing in India, orthopedic, plastic, vascular surgeons who are plenty in India, nurses who are plenty in India, orthotists who are less in India. Now, the other way is to educational control. The step by step was a method where we uh, set up 100 foot clinics in India, Bangladesh, in Sri Lanka, and in Nepal. And this was in 2004-5. We started, followed by Africa, West Indies, Pakistan, West, and so on. It went like that. So, but in India was the first, we first formed the step by step along with Ali Foster. And this is Ali Foster who died of cancer. Arun Bal, the late Sharat Pense, and myself. We were at the uh, step-by-step training method, this training program, where we trained a doctor and a nurse. Dr. Banshi Sabu was also part of it. I don't know where he is sitting, but this is a doctor and a nurse. They were given accommodation and they were asked to grow debride calluses. Callus debridement was done with oranges, and we trained people over the basic course and an advanced course. The other important thing is the IWGDF guidelines must be followed. You have IWGDF guidelines which are for the whole world, and I was fortunate enough to be in the midst of David Armstrong and Catherine and Gustav. They're all podiatrists. Carlo from Italy, Peter Lazenby from Australia, and Sikobas was the leader from Netherlands. So we wrote up the offloading guidelines for 2023. It's very, very useful. Now, dressing materials, the use of newer dressing materials. Gone are the days when we used to use saline dressing, because for changing the dressing, you have to go on to a nursing home, to a doctor, to a podiatrist, to a bone clinic, which is very far off in India. You have to go in your husband's two-wheeler, or your son or daughter must take you in a car. So you have the Urgo Clean AG, which is available, which is costing about 250 rupees, but it's got a the it's got a TLC, it's got a method to it's got it's got a film. It's made of a film which traps the bacteria. And we also have the Urgo Start AG from Urgo, which contains the NOCF particles. NOCF stands for the sucrose octasulfate. There's a spelling mistake here. So it reduces the matrix metalloproteinases, speeds the wound healing, avoids wounds. So Urgo Start is very beautiful dressing, which is available in India. It's very much available in India. Costs about 300, 350 rupees, but you don't have to change it every day. So Urgo Start is a new dressing material, and it causes an imbalance detrimental to healing, and uh, it TMMPs, I mean, it destroys healthy tissues. So it reduces the MMP levels. NOCF, or sucrose octasulfate, reduces the MMP levels and restores the balance. It closes the wound sooner. So NOCF binding will stabilize the wound and also the proteases, and will help to heal faster. So this is Urgo Start from Urgo, which is a French company. My ex-president, Professor Jose Luis Lazaro Martinez from Madrid, Spain, and Mike Edmonds published that sucrose octasulfate dressing is quite useful in patients. It's called the Explorer study. And based on that, the IWGDF guideline has recommended the sucrose octasulfate as a primary dressing on the wound. It helps the sucrose octasulfate, which is available in India as Urgo Start, is is recognized by the IWGD. the whatever I say is uh, applicable only if you give preventive food care. So this pedicure I started in 1991. We teach patients how to cut the nails and how to use a pumice stone, and we help the my laser pointer one sec. So we help the people to use the laser pointer. I'm sorry, the pumice stone, and avoid barefoot walking, teach them foot care, and so on. So this is very important. Now the preventive uh, preventive chapter section of the IWGDF talks about 5 cornerstones of prevention of diabetic foot infection. One is the recognize the at-risk feet. As I told you, if 10 people enter your chamber, 4 people out of that are going to ulcerate in the near future. So you have to identify the high risk foot. You have to educate the patient, family, and healthcare providers. You should give the appropriate footwear, and treatment of the non-ulcerative pathology is the careless debridement. So if you do all these 5 things, you can actually prevent a diabetic foot infection. I would like everybody to go to the graveyard when we die with all the 10 toes, the 2 legs. So nobody should go with 1 leg or 1 toe missing. So this is my prayer, my wish that everybody should go to God or to heaven with 10 toes and with 2 legs. Thank you, Dr. Baraj, Sabu, and to the entire USV also I should thank for arranging this meeting. Thank you very much.
Thank you, Vijay sir. Thank you for this enlightening talk, actually. And what was most take-home point was a multidisciplinary management, which involves 6 prongs of diabetic foot management, as you said. And there should be 5 cornerstones for diabetic foot prevention. So 5 and 6 constitute the gist of your talk. We have a lot of questions, sir, for you. We have a question from Dr. Rajiv Lochan from Patna, who is asking about the role of pregabalin and nortriptyline in diabetic peripheral neuropathy.
I will answer the question, and then Rahul or Shivani and Akash can answer. Now, pregabalin, nortriptyline is only for painful neuropathy. I see many people using it for neuropathy, for getting back sensation. Dan Ziegler was the only one who showed that alpha lipoic acid, 600 milligrams, can reverse neuropathy. Nothing on earth can reverse neuropathy. So pregabalin is nortriptyline is only for pain relief. If you have neuropathy pain, it will relieve it. It will not reverse neuropathy. So this is what I had to say. Uh,
Very,
Rahul,
very well said,
Kash,
sir. Rahul, any comments?
Shivani,
What's your view?
you're muted. You're muted. Unmute
And
yourself.
also kindly unmute.
Dr.
Unmute,
sir.
Rahul, you are muted.
Yeah.
Yeah,
And
rightly
also
said,
kindly
sir.
unmute yourself.
Yeah, it only relieve the pain, not recover the variable neuropathy or regenerate the neurons in the body.
Dr. Rahul, would you like to add something to it?
Yeah. For diabetic neuropathy, glycemic control is the paramount. Pregabalin, duloxetine are just for symptomatic relief.
Very, very true. And this brings to one of our questions, which has again popped up. Well, how we should manage, Vijay sir, patient with diabetic foot and multiple comorbidities, because that becomes restrictive in our approach as far as glycemic control is concerned. A patient with DKD, heart failure, frail old elderly, what should be our approach for that patient with a diabetic foot ulcer?
A diabetic foot infection, if it is very severe, I will not hesitate to start basal bolus insulin because he is with me and I monitor his blood sugars 3 times, 4 times a day. We have the CGM today, so we attach the CGM. So let's not be worried about hypoglycemia, even if he's 70 years old. So the infection, if it is controlled, the the blood sugar is controlled within 24 hours. The polymorphonuclear glucosides, chemotaxis improves. So I think you have to be very aggressive, not just treat with antibiotics and so on, but give a basal bolus insulin and monitor the sugars with CGM or with blood sugar.
So tight glycemic
Shivani,
is the key.
Uncontrolled diabetes is the open window for infection.
Yes, Dr. Akash, very rightly said. We need to
Even
treat blood sugar. Dr. Shivani,
Yeah.
you want to add something to
Yeah.
it?
yes, yes, sir. As sir has rightly pointed, even if the blood sugar is controlled, then on oral antidiabetics, then switching to the insulin makes the healing faster, as insulin has anabolic action. So for the even for the small period of time, if for the temporary duration till the ulcer heals, then switching from OADs to insulin definitely improves the healing process and decrease the ulcer healing time.
Very rightly said. So, Dr. Shivani, we have one more question related to this because you have said about insulin, and sir is also emphasizing on insulin therapy in diabetic foot ulcer. What are the strategies you, as a clinician, found most effective in improving patient adherence to treatment related to insulin? Because it is a big challenge with all of us.
Yeah, as sir has rightly pointed that basal bolus insulin is the preferred choice for starting insulin, as pre-mixed insulin doesn't cover the lunchtime meal related rise in blood glucose level. So if the patient, if we want early healing, then basal bolus insulin is the best choice. And regarding the patient acceptance, definitely if the patient has ulcer and if we educate him or her that it is insulin is a kind of medicine for the ulcer only, then he accept it, because everyone has a fear of amputation these days. So
Very true.
he accept that if my ulcer is going to heal better with the insulin, then he accept the insulin. So we have to explain like this, that it is going to uh, fasten their ulcer healing time.
Dr. Shivani, it's like pregnancy. You're not going to take insulin lifelong.
Yeah.
You take it only for 10 months. Even if you deliver, you just stop the insulin. If you're not breastfeeding, you just stop it. If you're breastfeeding, you can continue some more time. But I think no harm in, and insulin is not something which makes you addicted to it.
Yes,
So,
most of the patient have this.
So I have had
so
experience. If I started insulin in a diabetic foot, then patient uh, uh, is asking from their side to, sir, we continue the insulin lifelong. It's really benefited.
Very true.
yeah,
Insulin is not
Actually,
addictive, but the glycemic control we get with insulin
Yeah.
becomes addictive to
yeah.
patient.
Patient feel good that yeah.
Actually, sir, thing is that first of all, we get the patient into confident that they will
Yeah.
start the insulin. Second thing is that once you say to the patient that this insulin is for 6 month duration, 3 months, then we'll see that how your body cope up. Then we'll try to stop the insulin. Then he will get an idea. Okay, my insulin will stop. He can continue. But once at the
Then our
first
duties
incidence only, if
duties
you
and
say that you have
insulin
to take
duties
insulin
started.
lifelong, they will very frightened. They are reluctant to start the insulin.
Yes.
Yeah.
So we move on to our next question, which is from Dr. Abhishek Raha. He is asking about role of good quality footwear with extra cushion, preventing foot ulcer or foot infection in patients.
see, the 70% of people do not require any diabetic footwear because they have normal sensation. They do not have limited joint mobility. They have little loss of sensation. That's it. So 70% do not. Those who ulcerate, those who have a 4-foot ulcer, definitely need offloading. The best offloading which we have written in the IWGDF is total contact cast, which is an irremovable cast. But only thing is you cannot see the wound. You can put a window and all that, but it's not accepted by many people. So there is a removable cast or the hair cast boot and so on, which you can use it in people who have an ulcer. That's 30%. So 70% can wear any footwear which doesn't hurt them.
Yes.
So your question was soft sandals. See
Yes.
that there is no stitches because you don't know, you don't test small fibers. So there could be small fiber neuropathy. So see that there's no stitches inside the footwear, which will rub against the insensate feet and produce uh, uh, infection. So footwear should be comfortable, even if you do not have neuropathy or loss of sensation. Footwear should be comfortable.
Dr. Akash, you were saying something regarding this? You want to add
Footwear is
something?
the footwear is the best choice to prevent the pressure that we repeatedly told patient that do not walk and do not pressure over the wound area. But unfortunately, they have to work or anything else for going to toilet or going to anywhere for walking, minor walking. The pressure is the culprit for the not going to heal that ulcer. So pressure control is the must. So we have to use the footwear regarding the diabetic foot.
Dr. Rahul, this is
Yeah,
the routine practice with you? You
yeah,
prescribe footwear?
basically, yeah, it's not a routine practice. Basically, we advise those who don't have any high risk foot or not no cons, no ulcer. You wear the soft, well fittable. Should not be any friction kind of footwear so that they don't get any kind of harm or they don't any kind of injury. Those who have ulcer or con, then definitely they will need the customized footwear to prevent the further damage. That is the way. And one advice for generalized advice for any diabetic patient: always wear slipper or any footwear. Don't walk by barefoot. That is the must
Barefoot.
advice for everyone.
This is the best advice, I think, for our patients. Uh, Vijay sir, there is one question, and interesting one. A type 1 patient with severe neuropathic pain, this is from Dr. Ajay Kumar Yadav. He's asking, he's having a patient with type 1 diabetes pain, multiple times visiting clinic in emergency for that pain. So how to control that pain?
It depends on the age of the patient. The patient is an adolescent. It could be the pain could be psychological. So you should give what is called psychological training, psychological support. Pregabalin is good for depression and for pain relief. So you can give pregabalin in, and you can add nortriptyline. They are good for depression and also for neuropathy pain. So I think type 1 diabetes and control the sugar also. If you control sugar, the pain might increase due to insulin neuritis initially, but that doesn't matter because the insulin neuritis is not a permanent thing. It's only a short-term affair. So I think you should control the diabetes and give pregabalin and nortriptyline, which will handle both depression and neuropathy pain.
We have one more question, sir, regarding this. This is from Dr. Paras Patel from Ahmedabad. He's asking pregabalin with duloxetine. What should be kept in mind while prescribing these two drugs together?
So we don't combine these two. We go by a stepwise approach. So the American Neurological Association has talked about pregabalin as the first choice, and then you add this is a calcium blocker. The blocks the GABA. The GABA stands for GABA GABA. So if it doesn't, then you add something which will attack the sodium channels. You can add Tegretol or something. So there's no point in adding gabapentin and pregabalin. You can combine pregabalin and duloxetine because their mechanism of action is different. But the side effects are more. the vertigo and all these side effects are more with if you combine the two. So I think it's better to go for a stepwise approach. I was scoffed at by the Pfizer company in the Pfizer meeting. They said they use pregabalin 600 milligrams. I said, what we use, don't use 150 milligrams also. They laughed at me. So they said, you don't use 600 milligrams. Then how will you get pain relief? So they wanted to use 600 milligrams of pregabalin, which we don't use in India.
Very true, sir. Dr. Akash, would you like to add
Yes.
something to this?
Pregabalin is the best choice, and we have to up titrate if pain relief is not there. And add on vitamin B12 is definitely the role of vitamin in prevention and to relieve the pain with pregabalin.
Very true. Yes, Dr. Shiva.
Our patient, I think, tolerate up to maximum of 150 milligram pregabalin, and after that, even on the 75 milligram, some patients start feeling the dizziness, and
Yes, yes.
so
Sedative effects.
That is there where initially with the initial doses it is more pronounced, and gradually the patient settles down. The patient usually comes back in next day in OPD.
Yeah.
Of vertigo and all
With
that.
that drowsiness and vertigo.
So we have to explain each and every patient that you may develop dizziness and you can reduce the tablet to half initially. So,
but that has its ill effect. So if you tell them that they have dizziness, they will definitely
Yeah,
have it.
definitely. But I practice that at 6 to 7 o'clock. They have to consume the pregabalin. So it's reduce the early morning
Yes.
effects, side effects.
Very true.
Yeah.
Vijay sir, we have a question from Dr. T. Vasanti from Chennai. She's asking best topical agent for chronic ulcer.
See, we published if you have a neuropathic ulcer, which is not healing for 4 weeks, we, Dr. Shekhar, myself, and Sharat Pense, we applied the EGF, epidermal growth factor, and it healed. But the ulcer should be 4 weeks old, and it should be neuropathic ulcer, no peripheral artery disease. And it is the region D, it's called, from some company in Hyderabad, I don't know. So the region D is used. It's useful for neuropathic ulcers. But in the IWGDF guideline, we did not advocate any cream to be applied on the wound. It doesn't help. Metronidazole does not help. You can read the IWGDF guidelines.org in wound healing chapter. There is no local application which we have advocated, recommended.
Thank you, sir.
Thank you, Dr. Bharat.
We have one more question from Ninad Gaur from Bhuj. Is there any role of epalrestret or aldose reductase inhibitors?
I only quote Dr. Andrew Bolton, who said it should be put into the dustbin. So I don't think any data is there, except a few Japanese studies. But I think in neuropathy pain, as Dr. Rahul said, and as Akash said, only glycemic control helps. The tighter control you get, the lesser the neuropathy. And you have pregabalin for pain. The aldose reductase inhibitors, the AGE inhibitors are all theoretical.
Okay. So we have one more question related to this pregabalin and duloxetine combination. This is from Dr. Arpan Shah from Anand. In CKD type 2 DM patient with long-standing neuropathy, what should be the maximum dose of this combination?
So you can go up to, as Shivani said, 150 milligram of pregabalin, which is the maximum tolerated dose, whether you have CKD or it is kidney safe. The pregabalin is kidney safe. It's not nephrotoxic. Duloxetine, you can go up to 60 milligram, but if you combine the two, be careful. you can get more side effects. So use one drug and step it up and use insulin and counsel the patient.
We are sorry, sir, but we are bombarded with lots of questions, so we are troubling you also. We have one anonymous question. How can a primary care physician better identify early signs of diabetic foot ulcer? Because this is a common problem in day-to-day practice.
Dr. Rahul, you want to answer?
Yeah. As a primary care physician, first sign of diabetic foot ulcer is the callus formation. Before that sensation loss, but if they can check the vibratory sensation or ankle reflex is the best sign for neuropathy. They can check that. Then look for the callus. And best advice they can give for the patient is to check the foot daily after taking the bath and clean the foot with the clean towel. That is the best way for the prevention also.
Very
I
true.
think you're very right. You should look for insensate feet. You should identify the high risk feet. As Dr. Bharat Sabhu said, the last slide, 5 points for preventing an ulcer, prevention of an ulcer is one is to identify a high risk feet, at risk feet. So that's very simple. You don't need expensive gadgets. You need only a 128 hertz tuning fork.
And
So that's all that you
I
need.
add on that advise every patient on every visit or every follow-up visit to check your feet at during bathing or anything that if nail on or during nail cutting, they have to look at the feet,
Yeah, self-examination.
self-examination.
Very important. Dr. Akash, we have a question that how important is exercise in management of diabetes, and when patient has diabetic foot ulcer, what do you suggest for exercise?
Uh, uh, During diabetic foot ulcer, you have to do not pressure over the wound. You can do yoga in a sitting position for better outcome. Exercise, walking or any pressure, it's not advisable.
Dr. Shivani, would you like to add something to this?
Upper body exercises can be done
Yeah.
even in the diabetic foot ulcer, but offloading is must if we want to get the ulcer healed. So while the patient is practicing the offloading, then he must do upper body exercise, provided he doesn't have sign of sepsis or fever. So if the patient can do, then upper body exercise is best, and he has to do
Patient can do exercise after total healing.
upper
Yes.
body exercise, but he can do
Yeah.
even in the
Very true.
because
But that was a very relevant question. I like that question because that is very important. Now, again, sir, Vijay sir, a question regarding the human recombinant protein-derived growth factor. There is a lot of talk about this thing. Does this help in neuropathic ulcers?
As I said, if your offloading has been given for 4 weeks, because it's costly, 1,000 rupees. So you should not use it for every Tom, Dick, and Harry. So for 4 weeks, it is not healed. This was the criteria we published in Wounds, Shaker, Sharad Pense, and me. So it should not have healed for 4 weeks. It should be neuropathic, no peripheral artery disease. And complete offloading has been given. Every measure was taken, and still it didn't heal. You can make the patient spend 1,000 rupees. Otherwise, 1,000 rupees, you are stealing the patient from the patient's pocket.
And it's a chronic therapy. It will go long and long. So
Yeah.
we again have a question from Dr. Kishore Behera from Bhubaneswar, that when you will place TENS for the treatment of diabetic neuropathy. This is again a new thing.
Dr. Akash, TENS.
I didn't get the question, sir. Can you repeat?
No, when will you use TENS in neuropathy pain? TENS.
TENS.
TENS. TENS.
TENS during
Neuropathy pain. So anodyne, they do not have much of RCTs. Anodyne, TENS. You need good RCTs
Yeah.
Okay.
to show that they are useful in neuropathy. Neuropathy pain, pregabalin, glycemic control, duloxetine, and nortriptyline, and Tegretol. That drug, I don't know, what getting the name, Tegretol. So these are the drugs which are used in diabetic neuropathy, not 10-xanodine and all that.
Yeah.
If you want to improve neuropathy, only glycemic control. None of these things help in improving the nerve fiber, nerve function.
I think it is like acupuncture only with the placebo effect.
Yes, placebo. Very true. And in between, I would like to thank and congratulate all the panelists, because we are getting a lot of comments which I'm not taking due to lack of time regarding wonderful session it is. Dr. Ajay Kumar Yadav from Nepal is saying greetings from Nepal. Dr. Prashant Shankar is congratulating Dr. Vijay Vishwanathan sir and whole team D Genius. It's wonderful discussion. Now again, a question comes to us, and I think we are running short of time, so I will not taking much of questions to you. I have already troubled you a lot. But this is a question from Dr. Ajay Kumar Yadav from Nepal. Most patients ask, doctor, can I walk barefoot in green grass? Any beneficial green grass foot? We know it will harm, but any no beneficial effects, because YouTube is flooded with such videos.
Not advisable at all.
So we first of all examine the foot. The patient does not have high-risk feet, at-risk feet, insensate feet. He can walk on beach sand. He can walk wherever he wants. So beach sand might be better because you get more grips. More grip is needed than grass. So, but first of all, examine whether he's got sensation. If something pokes him, if something is hot, he must tell you something poked me, something was hot. So he should tell you. If he's got insensitive, he's not going to tell you. Only after bulla comes, he will tell you, doctor, I have a big vesicle with fluid in it.
Mm.
So you should be careful.
So I have one more question, which is actually related to psychosocial aspect of diabetic foot ulcer. How do you address the psychosocial aspect of diabetes management in your day-to-day routine practice with your patients? Dr. Rahul, would you like to answer this?
Yeah. Regarding the psychosocial concern, first, the patient is having much apprehension about the amputation. That is the one main query for the patient. What will happen? What is the dead end of this diabetic foot ulcer? So first we have to counsel the patient regarding the, along with glycemic control, the foot care. What will be the complication? What will be the consequences? So that they can, if they have the confidence, they get to know about the gravity of situation. Then along with the ulcer glycemic control and ulcer healing, patient we will prevent the complications like amputation and reduce the stress burden. That is the one way we can. Counseling is the best way.
The
Yes,
only
very
questions patient ask that is it healing? Is it healing in every visit?
because they are always hopeful and they need hope
Yeah.
from us also.
We have to give the hope.
Yes.
There is some progress, but it is the long last process. It is not like fever with the duration of this much of antibiotic, it will get by 10 days. It is long lasting
Yeah.
process. And not only them, their family member has to be counseled, because it's the combined approach of patient, family member, doctors, and support group. That is the best way.
After treating,
Dr.
yeah,
Akash,
go
you
on.
just do a total WBC count.
Yeah.
And if it is normal, you can assure the patient that he is on the road to recovery.
Yeah.
Whereas the count is
But
increasing.
sir, in this there is some kind of immunopathy in diabetes. So do you believe if there is a counts are not high, then there is no infection as such?
So you can do, if the patient can afford it, you can do a procalcitonin level.
Yeah, that is the,
So, but that is expensive.
yeah.
So total WBC count is going up in 90% of people. In immunocompromised individuals, yeah, what you said is correct.
Hmm.
But WBC count, we do it once a week. You can know where you're heading.
Hmm.
Whether the infection is increasing and so on. We have two studies going on with bacteriophages, putting viruses there, viruses which remove the biofilm and all that. So we have one study with Amrita Institute and one by a company, American company, where we put bacteriophage into the wound. You must have heard of maggots in the UK. So we are now putting viruses, bacteriophages into the wound and trying to improve healing, trying to reduce the bioburden of the wound. So I think more and more newer technologies are coming.
Very true. Uh, this actually is getting very interesting, but I will just ask you all one question each because we are short of time. We have a lot of question to answer. We have a question: dressing that use modern technology like 3D bioprinting, photothermal effect, bioelectric dressing. What are the roles of all these things? Are there any studies, and what are the challenges with that? Dr. Rahul, can you take this?
Can you
The
sir repeat the question? I am not good.
all the newer technologies which are coming with diabetic foot, like the 3D bioprinting, photothermal effect, bioelectric dressing. We now have microneedle dressings also, smart bandages, all these newer things in diabetic foot technology. Are there any trial data or any scientific data to support all these things? Do you have any
Right now,
for this?
we don't have that much of robust trial to prove this one. They are in the trial process. Until and get we'll get the solid data on this. Till that we can't recommend it that this should be the in usage as regular.
For newer technology are trial and error always.
Yes,
Dr. Bharat Sabhu, I think you need good RCTs. Good
yes,
Yeah.
RCTs to show that these expensive technologies are much better than saline dressing. But one thing is what I showed Urgo Start, Urgo Clean EG, and those products are beyond, they have been shown to be useful and they are much better than saline dressing. Saline dressing was in one arm, standard control, SOC, standard of care or treatment, and the other arm was the Urgo Clean EG, Urgo Start, and all that. So I think you have two arms. You need good RCTs, not a double-blind crossover study, but a double-blind, with good randomization.
very true. Dr. Shivani, I have a question for you, and I will not trouble you more, but how do you see the role of family support in diabetic ulcer? Because this is very integral part of a diabetes foot treatment.
I think family support is must, and because the patient needs the family at each and every step in diabetes management. Initially, during the dressing part, also they sometimes the family has to learn how to do dressing because we have to change the dressing sometimes 2 times a day. Then, if the wound is have a lot of exudate, and sometimes the patients are from rural setup and they can't go for dressing daily to the hospital, so family support is must in diabetic foot healing. And also sometimes the patient can't administer insulin by himself or herself during the acute illness. So in that part also the family also play important role. So I think it is a team approach by the family members also.
Very true, very true. Dr. Akash, I have a question for you. We have talked about
Yeah.
everything, exercise, drugs, and all the things related to it. This question has come up because are there any specific dietary recommendations for diabetic foot? Because people have various myths around looking at the YouTube channels and all those things. So do you have any scientific data for that? Have you come across anything?
I think foot ulcer is localized. Okay. So with diabetes, you have to stick to the diet with no sugar and proper diet, calorie deficient. I think 800 or 1000 or 1015 or 500 kilocalorie per day consumption is good for if a bed ridden patient or if a doctor is advice do not move if you are not wearing the diabetic foot shoes or anything, then calorie deficient and the control carbs control is necessary for that.
Very true. And it is very well said that diabetes control is the gist. There is no specific drug or food which actually impacts diabetic foot ulcer. Now, Vijay sir, just the last question to you, and this is from whole of D Genius, because we are a vibrant young community of doctors. You can see what are the current gaps in diabetes food research which you want us to come up, and we need to address it. We will be there with you to address the gap.
I think the Save the Feet campaign showed a very high prevalence of foot ulcers, foot infection, and it unearthed. It's getting published in BMJ in another 1 week's time. So the thing is, we would like DGNES, we would like Diabetes India to take up research in trying to unravel these secrets of India cannot afford costly treatments. India cannot afford it. And diabetic foot does not require all these expensive gadgets. So I think DGenius and Diabetes India should work together to validate all these newer technologies and say that to heal a diabetic foot, this is the cheapest method in India. This is you'll be doing the country great help by doing this. The whole country will appreciate it.
Definitely, sir. Everyone is with you in doing this. Definitely. There are a lot of things to talk about, but we know there is a paucity of time. We cannot keep Vijay sir hanging around for so long. Before I hand it over to USP for the final closer, I would just like all of our panelists to give one take-home message for all our practitioners who are watching. Starting with you, Vijay sir.
So I think the main message which I want to say is physicians are an integral part of DGenius, Diabetes Care, Diabetes India, RSFA. We are all together. We are physicians. We should show the world that we are captains of the ship, diabetic foot ship, and we are going to take the upper hand. The moment the foot ulcer comes up, the diabetologist says, shift, take him to the surgeon. That attitude should stop. So we are a strong force, and I think DGenius, Diabetes India, RSDA should get together and get all the physicians interested in diabetic foot. That's why I said the topic is what the physicians should know and do. That was a topic which I gave you to talk about today.
Excellent.
That's
message,
my final message.
Dr. Shivani, your take-home message?
I think we should identify every high-risk foot early and advise the patient preventive measures. And if the patient develops ulcer, then we should actively involve the patient in healing and keep their hope alive.
Wonderful. Dr. Akash.
Yes, sir. If patient got amputated, if one toe, two toe, any, it feels very bad for diabetic expert or diabetic foot experts. So save the feet and don't go for the amputation. Early ulcer management is the key.
Wonderful. Dr. Rahul, what's your take home?
Or diabetic and its related complication. First of all, we need diabetic complication free India. So at each level, every visit, all doctors, all healthcare workers should screen for the complications of diabetes. Not only diabetic foot, but also nephropathy, neuropathy. Along with that, glycemic control is the key. And third most important thing is the blood sugar monitoring and dietary advice.
Thank you.
Dr. Bharat Saboo, you did a fantastic job today in moderating it. You are a epitome of knowledge yourself, and you just asked us questions. So thank you very much. And Sachin has been such a dynamic person behind the show. And thanks Sachin also for taking up this cause of diabetic foot.
Thank you, sir, for the compliment, but the compliment goes to the vibrant audience because without audience, without their queries, a topic is not justified. And all thanks to you, because you brought this topic to life. All our eminent panelists, we added their expertise and made this a beautiful recipe to serve to all our members of DGenius and beyond. Over to you, Sachin, for the closer.
Sir, I'm Sachin. I'm just 17 years old with the just 62 years young company called USB. Really thankful to everybody. If we put these all experiences together, all comments together, then definitely the one aim which is being spelled out here is to save the feet, no amputation, or rather zero amputation. So like very kind regards and salute to you all. Thank you so much, Vijay Vishwanathan sir, for the kind guidance. Rahul sir, the way it has been explained to all our 1,400 plus very kind audience, they learned so many things towards the objective of the Digimed group of saving the feet. Thank you so much. So is the Akash sir. So when you answer that, like, is somebody should walk, on the grass barefoot, yes or no? The way you answered very nicely. Sure, ma'am. Thank you so much. And ultimately, like the Bharat sir, the way like it has been, it was not like a session which is going on. It's a truly one-way dialogue, two-way dialogue, then the three-way dialogue, and it was just a series of the dialogues. Thank you so much. With your kind permission, like let me share the screen.
Sachin, just a moment. I would like to invite all the people who are joined here for Diabetes India 2025 in January. Don't miss the show. Save your dates.
Yes,
January 2025, Diabetes India. Sorry, over to you.
Yes, Diabetes India. Yes, I got it, sir. Yeah. So, sir, I just said that we are just 62 years young, with the kind support of all our audience. Our every fifth prescription in the diabetes contains the OAD from the company which is very close to my heart as well as in mind, that is USB. Yes, we are very proud to say that we are leaders in the cardiology as well as the diabetes oral. Global leaders, we are saying so because the metformin, one out of the every 6 tablet is being sold, is being supplied by the USB and having very strong presence in 64 countries. Very respectful gratitude to users, to your family members. Why? Because we aim that like India to be recognized as the metabolic care capital of the world and not the metabolic capital of the world. That's our simple, small, significant dream that we want to have. And the roots where we can count this kind of a dream is founder of the USB, Dr. Vittal Balkrishna Gandhi sir. Then his successor, Arvind Vittal Gandhi sir. Then our current leadership, our chairperson, Mrs. Leena Gandhi Tiwari, our managing director, Mr. Prashant Tiwari. The work is, I'm not saying, yeah, it is to the corners, so that even the municipal corporation of the Mumbai has also recognized the 2 streets in the Mumbai in the name of our founders. If you see here, so like he was also the economic advisor to Jawaharlal Nehru, sir. Like when there was a delegation led by Nehru sir to the Japan. If we see, I just, yeah. Yes, sir. So, sir, if we see the backbone, so there is an API happening in the Chiploon, as well as our factories are in Ambernath and the Chiploon. The biologic plant is in Nerul. If you happen to come to Mumbai, you are most welcome, sir. Even the Daman plant is similar, like having the finished dosage formulation plant is there in the Daman, as well as the Baddi. Your good self is happening to be in like visiting these places. Kindly let us know. You are most welcome to visit our plants, sir. Sustainability is something which like we are very serious. We are not doing everything, but we are taking these small steps towards it, so that we can have this solar power, we can have the zero liquid discharge, rainwater harvesting, to the best possible the paperless manufacturing per lab, and when we are talking about the green belt, then like we are having the almost 800 plus trees, having the 3,000 plus, covering the 3,000 plus square meter area. As we said, sir, one of the 6 of the world's requirement of the metformin is being supplied by the USV, no doubt. What is the most important to your patients, and that is our promise, is the quality of the metformin, which, and it is as per the US FDA, NDMA that we are ensuring. Therefore, sir, the analysis, the result of the most recent 44 batches of the glycomet SR confirms the NDMA specifications powered by the FDA, sir. Thank you so much. Ecosprin, Ecosprin AV, Ecosprin Gold, Ticaspan, Ricosprin, Glinase, Triglinase, Glycomet, Insutwic, Liraline, Chaldra, Udapa, Rosde, Tazlog series, all to have the comprehensive patient care so that we can build the better metabolic care capital of the world. We also believe that it is not, knowing is not the just enough. Like we must apply. We are doing that. We wishing that it is, wishing is not enough. So we must do. And if we want to change, see the change, we believe that like we must be to be the part of the change. And to have that, so we are having the various awareness programs, screening and the diagnosis program, education, research, and the infrastructure and the capacity building. When we are talking about the awareness, we are there on very active, we are having the various awareness programs on the media.com platforms, radio, Facebook, Instagrams, as well as the print. When we are talking about the screening, also we are having since 5 decades, having the screening in the field of the hypertension, dyslipidemia, complications, diabetes, obesity, and still going on. And therefore, we are, and this is a very significant step towards making India as a metabolic care capital of the world. As you know, like Vijay sir was saying, research is very important, probably its foundation. So therefore, we are encouraging the research. The ESI AV Gandhi, that is the Endocrine Society of India, and the AV Gandhi Award of Excellence in Endocrinology was installed in 2002, still going on. AV Gandhi, along with the SCI SCA Award for the Excellence in Cardiology. So that's the Award of Excellence in the Cardiology. So where we are encouraging the research in cardiology. Then the ESI AV Gandhi Award in the PhD endocrinology. So this is the second year that we have installed. There was a request, and there's a PhD research going in the field of the endocrinology, and that was to be encouraged, which well supported by the USV. We are having the continuous medical education programs in collaboration, definitely with the RSSDI, with the SCI, Indian Society of the Hypertension, the Association of the Physicians of India, as well as Endocrine Society of India. Our partnership with the healthcare of professionals is well known, well proven, and when we are talking about with this partnership, the capacity building with their advice, we are having the capacity building in terms of the ECG learning. Save a Life. I'm very proud to say, sir, Save a Life is a CPR program. We have educated 1 lakh plus audience how to perform on CPR. With your permission, I would like to use the statement that I am very proud to say that due to this program, 17 lives been saved under the program called Save a Life. Also, we have the NDAP, which is entering into just 14 years, like creating 20,000 plus, 22,000 plus diabetic educators. India Insulin Education Program is something, like which we want that, yes, our caregiver, the healthcare professional, like to be the part of this also. So we are having the various programs like My Care, T1D, NIEP, CIEP, as well as the insulation for India. As we say, sir, sustainability is something which, like everybody at USV is very serious. We are talking about the plastic neutral. We are reducing the carbon footprint, as has been like the mentioned earlier. The one most important thing is that the recycling plastic water waste is being created by our insulin pens or the Angispan TR bottle to make our product plastic neutral. So we are using the recycled plastic. we are also creating the awareness on the right disposable of the sharps and the insulin needles. With this, I kindly stop here, thanking everybody. Thank you so much, sir. Thank you so much, our audience.
Thank you. Thank you, everyone.
Thanks. Good night.
Thank you, sir.
Bye. Good night.
Thank you. Thank you.